You're listening to Be Health Connected, a podcast by the Gateway Business Health Coalition. Your host for today's episode is Laurel Pickering, BHC President and CEO.
Hi, I'm Laurel Pickering, President and CEO at the BHC, and welcome back to the BHC's Be Health Connected podcast. As many of you know, BHC actively monitors and testifies on bills that could potentially impact employer-sponsored benefits. We actually have a lobbyist that we've hired to work with us in Jeff City in Missouri. So it's a real commitment to the coalition, and we know that many of our members rely on us to stay on top of the policy issues affecting them and be their advocate, whether it's in Jeff City or at the federal level. We're clearly focused on topics that keep care affordable, improve quality of care. And since I've joined, I've been diving into policy in a way that I haven't in a very long time. And I have made one trip to Jeff City with Mark, who is our guest, who I'm going to introduce shortly, and had the opportunity to meet some of the legislators there and testify on a couple bills that are important to the coalition and to our members. So I am joined today by Mark Dalton, who's the political director for the Carpenters Union of Missouri. He is also on the board of the Midwest Health Initiative, which is our sister organization, which many of you know about. And a little fun fact about Mark is that he actually started as a carpenter in the union and is now the political director, which is fun. And I'm also thrilled to be joined by Sean Greminger, who's the president and CEO of the National Alliance for Healthcare Purchaser Coalitions, which most of you know is our umbrella organization for all the coalitions around the country. And many of you know that Sean joined us at our annual meeting in November to give the federal and national perspective on health policy right after the election happened. And you did such a great job, Sean, and everyone was really impressed with your ability to come just a day or two later and really give us all perspective on the future. So we are going to be diving into policy issues that affect employers and would love both of your unique perspectives at the state and at the federal level. And I have been with both of you meeting with legislators in Jeff City and in Washington. So this is just nice that we could come together and have this conversation. So thank you for joining me.
Yeah, thanks for having me.
Pleasure.
All right, Mark, we're going to start with you. We're going to start small and then get big. Start at the state level. Let's start by talking about some of the hot topics at the state level. Now, you spend most of your time in Jeff City and are, very active with legislation statewide. So tell me some of the most significant policy trends that are currently being discussed at the state, and especially those that could impact employer-sponsored benefits.
Yeah, to talk about some of the topics being discussed, transparency is a huge topic between businesses, companies, purchasers, and their PBM and the pharmacies. The transparency has been a huge topic. I think most people are on the same page as that. Everybody wants transparency. It's just a matter of how and where. So those are the things being discussed in the legislation. The other topic that is a huge discussion is the keeping independent pharmacies in the rural areas afloat and making sure that we're not losing services in the more rural areas of the state. And then also just the options in which businesses or fund plans can set up their benefit plans. Some of the topics being discussed restrict some of those abilities. So those are kind of the main trends that are transforming the legislation we're seeing.
So you mentioned, all issues that we've been tracking that are important to us, transparency clearly being, one of our major values, one of the major areas that we think are critically important. With the Midwest Health Initiative, which you sit on the board of, we do reporting on providers. We're part of Leapfrog, anything that's going to be able to reveal the true cost and quality of care, critically important. And then pharmacy benefits. So pharmacy benefits continue to be a hot topic in the Missouri legislature. and everywhere nationally as well. And I know Sean is going to talk about that. But can you walk through how some of these bills have the potential to increase pharmacy plan costs for employers and their employees? You did touch on the independent pharmacy issue. I know the whole narrow networks is something that's been discussed, and limiting the ability of employers to narrow networks, as well as certain pricing models. But I'd love for you to just talk a little bit specifically about some of the things that we're seeing in those bills.
Yes, some of the things in there are directed at how a business or a fund plan can set up a PBM to operate on their behalf, and what model they follow. It restricts some of those options, which will have a cost effect on the payer. The other portion of any willing providers where they are looking to restrict the ability of a plan to direct their members in a certain direction or away from certain pharmacies. As far as labor goes, that's an important issue for us because you were able to direct our members to certain specific pharmacies we know we can get better deals on, or away from other pharmacies. Another issue that in labor, we support businesses that support unions, and the opposite side of that, we avoid businesses that do not utilize union labor. So our ability to focus on, if there's a larger pharmacy that is not using, our members to build their pharmacies or to do work on their pharmacies, we can, direct our members, hey, let's avoid these pharmacies because they're not supporting us, so we're not going to support them. So some of the legislation in there affects our ability to do that. And then our specialty pharmaceuticals, the Carpenters have a nationwide plan to target the very high end pharmaceuticals. And that saves our plan in Missouri at $5.1 million a year by mailing out those very high end pharmaceuticals. Some of the legislation that we're looking at aims to eliminate that, to where we can require our members to get it this way, and that's the way that helps our fund, our benefits fund, save costs. So there's several different ways our fund spends. In Missouri, spends about $41 million a year on pharmaceutical coverage. When our administrators are looking at the legislation out there, it could be an impact of an increase of 18.5%, which is significant, if all of the legislation that's out there were to go through.
Wow, those are really big numbers, Mark. I did want to touch on the issue of any willing provider, which I translate into limiting the ability for employers and funds to have narrow networks. And I think about that in terms of both pharmacy and medical, right? Like, we want our members to have the flexibility to narrow a provider network if they want to narrow a pharmacy network, because there's usually huge gains in cost and also quality in many respects. So that's something that we're going to continue to advocate for, and we think is critically important to employers' ability to run their benefit programs in a cost-effective way. So maybe before we turn to Sean, Mark, tell us, it's one thing to know these things are being proposed in bills. Where are we in terms of the process? Like, how likely are some of these bills to be passed as laws, and where do you see them going in terms of this legislative session?
So this session is halfway over. So usually the beginning half of session is bills are filed. You have hearings, so you get your public testimony for and against. And then the second half of session that we're just starting is really a lot more floor time, where bills hit the floor and you really start negotiating on those. So right now we've got Senate Bill 45 dealing with PBMs in the Senate that has passed out of committee, and that's on the floor calendar. And then you've got a couple of House bills, 982 and 840, that were rolled together. They were identical, but those two were passed just last week as well, and out of committee. So both of those are starting to move to the floor, and the negotiations on what can stay in those bills and what will get pulled out are underway. And so there's with as many bills that are filed in Missouri, there's over 1,200 bills in the House filed, and the Senate hundreds as well. So there's very limited on what actually gets passed. But the this topic has been around for a handful of years and has been intensifying every single year. And there's a lot of legislators that want to see something passed so that they can move on from this topic. So
Mm.
there is a good possibility something will get passed. We're just trying to make sure that it's nothing that will have some unintended consequences and cause some plans some additional finances.
Great. And just so our members know, we'll be working with Mark and our lobbyists and tracking all of that and providing input. All right, now to Sean. So, Sean, much of your career has been spent in federal health policy and some state as well, but in Washington. And we're really thrilled that you bring this expertise to the National Alliance to help a lot of us that need some coaching on how to talk to legislators and policymakers. So can you tell us about the legislation right now that National Alliance is most focused on at the federal level? And, one thing that we always come back to is ERISA, right? We need ERISA to stay intact so we can continue to have the flexibility to offer our benefit plans nationally for our members. So maybe start with there and talk about what you're seeing at the federal level in terms of threats to ERISA and then other bills and legislation that you're tracking.
Sounds good, Laurel. So actually, our number one short-term policy priority is very much related to, or at least has overlaps with issues around ERISA preemption. So in the short term, by which I mean first half of this year, Mark said, your session is about halfway over. Of course, in Congress, we have 2-year sessions that kind of go on forever. So we are still very much kind of in the first quarter of the entire cycle, which will not wrap up until November, December of 2026. Our immediate first term or short-term priority is on passing comprehensive PBM reform. And there was legislation that was nearly passed back in December of last year. It has bipartisan, bicameral support, support by both the outgoing Biden administration and, to our best of our knowledge, the incoming Trump administration. And it didn't get across the finish line because of sort of other political reasons unrelated. That PBM reform legislation would do a number of things. It would require end-to-end price transparency for PBMs. So employers and purchasers for the first time would be able to know exactly what their PBM, or actually their group purchasing organization, sometimes known as a rebate aggregator, paid for a drug. We'd be able to see all of the discounts, all of the fees, all of the rebates. And it would require in the commercial market that all rebates are passed on to plan sponsors. It also made some additional changes in the Medicare and Medicaid markets. We were really hopeful that that would get done in March. As part of the most recent funding bill, it did not. So at this point, it's quite possible that we may be looking at it not happening until maybe this fall at the earliest, which is obviously disappointing. The reason that it's sort of related to ERISA preemption is I think it's been the lack of federal action on PBMs for the last decade that has prompted a lot of states to start trying to create PBM legislation at the state level. Some of which is well-meaning, some of which actually will increase costs for plan sponsors, as Mark described. But one of the concerns we have is that whether it's good or bad legislation, sometimes it violates ERISA preemption. So I think most of your listeners will know, but self-insured health plans are regulated at the federal level under the Employee Retirement Income, ERISA, Employee Retirement Income
Security
Act, known as ERISA, that goes back to 1974. And ERISA has a strong provision that says states cannot regulate self-funded health plans. It can only be regulated at the federal level. When you look at state level legislation around PBMs, it may or may not violate ERISA. And I don't want to provide any comments on whether the current legislation in Missouri does, because I have not taken a close look at it and I'm an ERISA lawyer. But basically, our line is, if the state is telling a self-funded employer how they have to design their benefit plan, that probably violates ERISA. So even if the state passes it, there's a reasonable chance that it would get overturned in federal court, which seems like a waste of time and a waste of effort for all of you who are working at the state level. But it's also part of the reason why we've been trying to push this to get done at the federal level, because we understand why state legislators are frustrated that people are unhappy with PBMs. They're too opaque. They aren't necessarily providing all of the discounts and rebates onto employers. They are arguably putting independent pharmacies out of business because of their business practices. So it's understandable why state legislators want to go there, but it is still probably a federal issue in a lot of cases. Looking further down the road, there's a number of other pieces of legislation, or at least areas of legislation, that the National Alliance is pushing significantly. So first, I would start with increased transparency, just as we started with kind of the focus in Jefferson City. One of the areas that employers often express frustration is that they are unable to see in full detail their claims data. And that theoretically should have gotten taken care of under what was called the Consolidated Appropriations Act of 2020. So legislation passed 4 years ago, which basically says we should have access to our own claims data. Unfortunately, a lot of insurance carriers continue to deny access or make it very difficult or only provide some of the data that we need. And so the National Alliance is strongly supportive of legislation which would provide real meaningful action to enable us to see all of our claims data upon request so that employers can actually make better plan decisions. We've been working on legislation to try to stem the tide of consolidation in the hospital market. We know, there's a mountain of academic evidence that shows more consolidated markets are higher priced. The more you have, a dominant 1, 2, or 3 hospital systems in a metro area, the higher prices are that they charge for employers and purchasers. So we've been trying to stop further consolidation and then try to at least mitigate the impact of consolidation by banning anti-competitive contracts between hospitals and health plans. We've had a small degree of success, but we really have a lot more work to do on that end of things. There's some interest, maybe for the first time among Republicans, on actually taking on the pharmaceutical industry. President Trump's sort of starting point on prescription drugs is somewhat different than where Republicans have been in the past, traditionally. And there are leading Republicans, particularly in the Senate, that have said, hey, we should cut down on or try to stop some of the patent gaming that we by brand name drug makers to keep their drugs on patent for longer. And it would be a huge success if we were able to stop things like what we call patent thickets, where a drug company will put dozens of patents on a single drug, or patent evergreening, where as the drug gets closer to having its patent in, they add a couple more patents on at the end. There's a number of different mechanisms that drug companies try to use, and we're obviously very focused on trying to change that. And then, of course, a program that is, I was going to say, near and dear to my heart. What I mean is a program that I have dealt with my entire career, which is the 340B drug pricing program. This is a program that was created back in 1992. It was originally designed to mitigate the unintended consequences of the Medicaid drug rebate rule, which was passed in 1990. It enabled core safety net providers, so community health centers and kind of core urban safety net hospitals that treat a lot of uninsured and Medicaid patients, to buy drugs at a discount, which would then allow them to use those savings to try to invest in low-income communities and low-income people. It has been expanded beyond, I think, anybody's wildest imagination. Today, more than half the hospitals in the country now participate in 340B, including a whole bunch of them don't in any way resemble safety nets. There's a lot of reasons for that expansion. Hospitals and community health centers will now have very large pharmacy networks that they call contract pharmacies, so that they can capture a whole lot of drug claims under their system. And it's causing employers and purchasers a lot of money. Because when 340B expands, we lose access to drug rebates that would otherwise be negotiated with us, for us, by PBMs. It drives consolidation, and there's really strong evidence showing hospitals that participate in 340B price their drugs higher and prescribe more high-priced drugs than non-340B providers. So the cost to employers and purchasers is really significant. There is now state legislation all over the country, and I think in Missouri, to effectively lock in the use of these very large contract pharmacy networks. Again, I think for a lot of legislators, it looks well-meaning. They want to protect a program that is legitimately helping core safety net hospitals, rural hospitals, which of course are very financially challenged, community health centers. The challenge we find is that most of the growth in 340B, in fact, now about 75% of the program, is in large consolidated healthcare systems around the country who are making huge profits on being able to buy at a discount and then charge commercial insured patients at a higher price. And it's unclear that any significant amount of money is actually ending up in the hands of low-income patients or in the economies of underserved communities. So we've been very focused on trying to stop stupid legislation at the state level, working with our coalitions around the country, and try to push instead better transparency into a program that continues to be opaque.
Yeah, and we're just beginning to educate our members about 340B and the impact. We had a webinar a couple months ago, and I think there's clearly more that we need to do, because I agree. I think a well-meaning program that is now going to hospitals that, are making enough money, probably don't need that extra. Mark, I know we do have some bills at the state level in Missouri. There was one, I understand, that was passed last year, and we thought that the 340B issue had been handled, but it came back again. Can you just say something about what's happening at the state level with 340B?
Sure, and that is kind of typical with legislators. They'll pass something and then come right back and try to get more. So last year, the bill that was filed this year was the same exact bill that was filed last year. Last year, they had a lot of things in there, trying to expand the contract pharmacies even further, and that was reduced down quite a bit and ended up passing. And that was kind of a compromise that everybody said, okay, and it was, had an impact on the pharmaceutical manufacturers without expanding, the contract pharmacies a huge amount. Everybody kind of agreed. Both sides said, "Hey, we'll do this and we'll let it go for a while." And then January, another bill was filed that was the exact same as last year, and they just said they wanted more. So that one has less of a chance of passing as is because of that exact thing. Everybody negotiated in good faith last year, came to an agreement, and then the opposition is coming back pushing it even more. Last year the hospital association supported the bill. This year they're opposing this bill. So that is quite a change when we've had the people that have been on the opposite side of the same bill for the last 5 years are now on the same side. That's sending a message as well as, maybe this is going a little bit too far. So we anticipate continuing to fight this legislation again this year in Missouri, and hopefully it will not just continue to come back.
Thank you both. This is a very helpful overview of what you're working on at the state and federal level and the issues that we should be tracking. Do you have any parting words for our audience who are, mostly employers purchasing health benefits, either in, why they should be paying attention to what's happening at the state and federal levels in these regards, but maybe just one bit of parting thoughts. Mark, you first.
Yeah, I would appreciate everyone just paying attention to what the Business Health Coalition is doing. It's a lot of good work, and on the state level, we're going to continue to fight against some of the negative policies that are going to have a financial impact on your plan. And hopefully, we're counting on Sean and the federal level to get some things done there, because that's where it should be done instead of a hodgepodge of state by state.
Agree. Sean?
I'd like to echo that thought. I hear all the time on Capitol Hill, we don't hear enough from employers. And we know certainly they hear plenty from hospitals, health plans, and pharmaceutical manufacturers, and doctors and pharmacists. They hear from a lot of them. And often the employer voice is sort of drowned out. So I would strongly encourage all the members of the BHC to get involved. I recognize that there is a challenge, putting your own corporate name or if you're a public entity, your county or your city name, or even in some cases, your labor union name on a piece of legislation. The best I can say is if you can participate by, going and visiting legislators or leaders in Jefferson City or DC, usually the role of the employer in that room is to just describe the problem, own sort of, this is what we're experiencing. These are the challenges that we have. These are the trade-offs that we're having to make because of higher healthcare costs. And then, let the experts like Laurel, myself, Mark, then own the solution and say, and we have legislation to do X, or we oppose legislation because of the trade-offs that employers, purchasers, labor unions, and working families are having to make.
That is excellent advice, Sean, and something that I would reiterate as well. We have opportunities with the National Alliance. They take us on the Hill and to visit legislators and are always interested in having employers come along. And the same with in Jeff City at the state. Also would love for any employers to accompany me and meet with legislators. And that's an open invitation. So please consider that. Well, thank you both so much for sitting down to talk with us today about this timely, important topic of health policy and what's happening in the state and federally that are going to affect plan sponsors. And thanks for listening to Be Health Connected, empowering healthy workforces one conversation at a time.
Thank you for listening to the Be Health Connected podcast. For additional episodes or to learn more about employer resources available through the Gateway Business Health Coalition, please visit www.gatewaybhc.org.